want to talk a minute about the team and how we use the team together. We've got a lot of expertise from different areas on this panel. How do we work together better to take care of our patients and prevent CINV? Let me start with you, Jim.
Well, certainly at our institution, from a pharmacy perspective, we are really involved in global order writing, from putting, front loading in the EMR with this regimen. This is what we recommend from a anti-medic perspective. Then certainly on a direct patient care basis, we're integrated in all the teaching services and rounding services as well as in the outpatient clinics. So we'd review those patients prior to coming in. We'd make those phone calls to patients saying, how did you tolerate your last cycle of chemotherapy?
So you make the phone calls?
Yeah,
Pharmacists make phone calls?
Pharmacists,
Interesting.
yeah, we do make some of those phone calls. Not all of them, but certainly those patients we know that are problem patients or had problems in the past or high risk for whatever reason, we will make those phone calls. So we do try to have an integrated and certainly talk with our nursing staff because it seems like they trust the nurses the most to tell them what really happened with last cycle of chemotherapy. So we would work with in the medical staff as well to come up if we have to change from what's loaded into the EMR.
From the nurse's perspective, Rebecca?
Just reiterating the same thing. It's truly a multidisciplinary effort. Working with the physicians, the pharmacists, the social workers, the nutritionists as well, our palliative care services. We're all one community under one roof, so that's how it works.
And I would say social work is vitally important as well.
Yeah.
With all the different insurance programs out there and formulators are out there, it is a challenge. Even if you want to use a certain regimen, I know somebody had mentioned, sometimes you just can't based on the patient's insurance or other circumstances from a reimbursement standpoint.
Yeah, I would definitely emphasize that. So we have an emerging class of one of the team members, the financial counselors, and I think the financial counselors here are very important, even when it comes to supportive care drugs.
Well, even before a patient starts their treatment, they need to meet with a financial counselor and go over a plan. Yeah.
I think the medical oncologist role here is to be humble. And the reason why is we're not necessarily always getting the information. And so if we don't hear about it, I think our assumption is that it's not a problem. And I think that patients are afraid to tell us, even in this day and age. And so if we're hearing from our colleagues that our patients are worried about that, we need to trust them.
And I think maybe we need to level set better with our patients and tell them up front and repeat to them, tell us about your symptoms. Your control of your cancer is not related to your symptoms. We can take care of your symptoms. And do you have any thoughts? You've had a career in symptom management and made so many great advances.
Listening to the nurses and the pharmacist and then coming up with a plan together. The doc can add a little bit to the process there, but listening to that, and again, it is a team approach. I agree.
I think a key message for medical oncologists to deliver is that suffering doesn't have to be in silence. We can control your symptoms and still be optimally aggressive about your care, and that patients who feel better live longer. And so I think those are the kinds of things that I try to tell them and repeat so that they're not just suffering at home alone.
I think also too today, the team is not just your team. We certainly are a referral center, and oftentimes we have to call the community oncologist or vice versa to get information and see how patients did, or what other information you need to make sure that you're taking care of them appropriately. So the teams are getting bigger now as care is being broadened across both community as well as academic institutions.
So it really does take a village to take care of a cancer patient. And as care gets more and more complex, we have to add more people. Absolutely. It adds more costs, but we're doing better. We're controlling symptoms and we're actually having patients live longer. So this has been extremely informative. We've talked about several new therapeutic options. We've talked about a number of everyday clinical scenarios that hopefully will help our audience and will shed light on ways to improve CINV management in your practice. Before we end this discussion, I'd like to get final thoughts from each of our panelists. Rebecca?
So as an oncology nurse and one that's been practicing for about 40 years, I believe that we are symptom managers. We are educators, and communication is key. Providing all the information that we have for our patients, and then to discuss it with our team once again to make sure that patients have the best possible outcomes. I can clearly say we've come a long way from years gone past. We have a ways to go still, but I believe that someday we'll reach that goal of hopefully having no nausea or vomiting for our patients. But we certainly can, using the guidelines and using them appropriately, provide our patients with the best care possible.
Thank you. Charles?
I agree. I think we're doing much, much, much better than we were 20 or 30 years ago. There's room for improvement. But in 10 years and 15 years from now, there will always be room for improvement. There are always, as you understand more things and this sort of thing, you say, what's the next step? What more can we make? So we'll never be at nirvana, I don't think. There's always going to be a role for us to make things better as we go along.
Thank you. Jim?
You know, I tell my residents and fellows, actually, this has probably been one of the biggest success stories in oncology. If you go back to the original Platinum, you know, back when there was just either high-dose Roeland or steroids, where really one out of 2 people had problems with emesis, to now with 3 drug regimens, you know, we're well into the 95% control rate. But Charles, as you mentioned, there's always going to be room to improve, and I do think there are some unmet needs that we've discussed today, but we're certainly made great advances in this area and need to continue to do so.
Thank you. Eric?
So I think a key message is that there's a lot of new tools out there. Just like we have a lot of new tools in oncology, there's new tools in this area. And if you don't necessarily, if you're not familiar with them, find someone who is. And I don't think patients and loved ones should be just at home suffering. And let us know, because we sincerely want to help you get through your treatment so we can be as aggressive as possible.
Thank you. So we're here to help. We have tools. We've made tremendous strides in CINV, and we still have some ways to go. So I want to thank all of the panelists for your contributions. It's really been a fantastic discussion. I really appreciate it. On behalf of our panel, we thank you for joining us, and we hope you found this peer exchange discussion to be useful and informative. Thank you.